Again, I'm very glad and happy that all of you are here and have so nice discussions and trying to solve the problems that we treat every day. And this talk now is not about my perspectives, but it is my thoughts, my agonies, and trying to share with you some thoughts of how to treat rotator cuff tears. So we know what is the rotator cuff. We must not forget that it's not the rotation only. The main function of the rotator cuff is the stabilization of the center of rotation of the shoulder. And what is happening when we are able to raise the arm and use our hand? It is a harmonious function of the deltoid, the scapular muscle, the rotator cuff. And this synchronous and sequential activation of these muscles makes this possible. Must not forget that it's not one muscle, one function. It is the combination of the function that makes function possible, the combination of the muscles that makes function possible. And what happens when we have a rotator cuff injury? First we have pain, then we have loss of strength. Practically, it's pain and loss of function, either due to the pain itself or due to mechanical reasons. At the extremes, it's pseudoparalysis, inability to raise the arm, external rotation lag, inability to externally rotate. So, if we think what is really happening is that when we have a tear of the rotator cuff, we lower the power reserves of the shoulder. And when the functional demands of the patient exceed the reserves, then there is a problem. If the functional demands is below the reserves of the shoulder, then the shoulder can compensate, the patient understands nothing. We can measure some loss of strength, but if he doesn't need that strength, then he has not a problem. So what we are trying to do then, practically, we are trying to restore this equilibrium. And the energy demands of the patient, the energy demands of the environment of the patient, and the capacity of the rotator cuff muscles are not only the muscle of the rotator, but the whole shoulder to compensate, to respond to these demands. And we know that back from Burkhardt that there is the force couples that stabilize the shoulder, the superior and inferior force couple, the anterior and posterior force couple. And this force couple stabilize in the two main places, the vertical and the horizontal. And we know that if these force couples are able to function, even with the tear of the rotator cuff, then the symptoms of the patient are mainly nothing or some pain. And it is a painful functional shoulder. And this is a stable fulcrum kinematics. And then we have a capture head, that we have a massive cuff tear and a functioning shoulder. Not perfectly functioning, but functioning enough for the patient. And this is a stable fulcrum kinematics again, with a massive cuff tear, with a large cuff tear. And this compensation we see every day. We see patients that have no problem or have minimal problems and a major distortion of the anatomy. How the body has found another way to function. Nature compensated by itself. A reverse shoulder prosthesis was made by nature. And then we have the worst scenario, the unstable fulcrum kinematics, anterosuperior escape of the humeral head, and then pain and loss of function, complete loss of function. And this is the big problem of the massive rotator cuff tears that lead to rotator cuff arthropathy at the end. And then it was this very nice paper for all these charismatic surgeons defining and separating the rotator cuff in five components. And these components may turn and some of them, or most of them. And what was ready? It's not only the size of the tear, it's not only the type of the tear, but it is also where the tear is that is important for the function. And then we had type B tears, which were those that disturbed function most, with pseudoparalysis in 80% of patients, and 20% of patients with this type of tear still functioning. How? Okay. And type T tears, type P tears that combined the superior and the posterior cuff and the loss of external rotation in combination with the inability to raise the arm. So, okay, we are surgeons, and when we have a tear that distorts the function and the equilibrium of force, so that's a problem in anatomy, let's repair the anatomy, restore the anatomy to restore the function. This is intuitive. This is what we think at the beginning. And then came this classification showing that this idea works very well for medium-sized tears, U-shaped tears, crescent-type tears that can be repaired, because there are tears that cannot be repaired. And then the question was, what we are doing when we cannot repair the tear or when the repair is going to fail? So, type 1 and type 2, things are simple. We have to do an anatomic repair. And if we do a repair, we must do the best repair that we can do. And then, what else we can do if we want to restore the function instead of operating? Okay, rehabilitate, strengthen the shoulder. If we have a cuff that it has a tear, and then this tear makes function impossible, if we strengthen the rest of the cuff, if we strengthen the scapular muscles, if we change the position of the scapula, then we can restore function. This is what makes rehabilitation. But if we repair, let's do it the best possible way. And remember that the components of a fixation is the configuration of the tendon suture interface. This is the weakest link. And then the type of sutures, the knot strength, the anchor type. These were told a lot by Snyder, by Burkhardt, and trying to find the best way to do it. And there are now so many configurations that you can use. It's a matter of fantasy and technology. And of course, the types of repair using single row, double row, transosseous repair. All these are ways to repair, and there are many now papers saying that repaired tendons of medium-sized tear work better and have a better function sustained in time. And then when we have large and massive tears, this is a different problem. It's much more difficult to restore the anatomy. We must find another way. We must be more, we have to think more of what to do. And practically, what we want to restore the function. So, how? First of all, when we have a problem. The age, patient motivation is very important. It's not only the age, it's what kind of patient, how well he is going to stand the rehabilitation process, the period of dysfunction that follows any type of operation that we do, the level of activity, where he wants to arrive, the stability of the joint, the chronicity of the tear, Patek classification, all of that are known. So, again, physiotherapy can increase the strength, can make better, give better proprioception, give better coordination. We have to use physiotherapy, and we have to explain to the physiotherapists what exactly we want from them. And then, when we go to operations, in-space balloon was just the reconstruction of the superior capsules. What are these? These are passive restraints to the superior migration of the humeral head. So practically, we try to change a dynamic component with a passive component. But what we try to do is to make a new way of stabilizing the humeral head, the center of rotation. And if we have a low motivation patient, then something very simple can be done and still solve the problem. If we stop the pain, if we have find a way to minimize the pain, then by rehabilitating, we can improve the function. This is happening by nature. When a patient is in pain, stop using the arm, try to lower the activity in order to lower the pain, and then again start trying to restore the function. Subacromial balloon spacer, we talked about this. Partial repair, medialized repair, all these are ways that we are going to change the anatomy a bit in order to make it easier to regain the function. Rehabilitation is very important again. Superior capsule reconstruction, we have Clara here, had a last course, and we know now that it works, especially when we take into consideration the vertical part of the instability. And then it came ideas of what else we can use, and the biceps was there, and bars and Achilles gave another option, an option that it was much more easy to use, much more quick to use, much more cheap to use, cost effectiveness. And we use it a lot now. And we know now that it's not only a mechanical problem that we have with the repairs of the calf. We must strive to increase the biological response. And we must do anything we know, anything we can, in order to do that. Because we need two things in order for the repair to heal. First, a strong fixation, a strong mechanical construct that is going to keep the tendons in place, whatever we put there in place for a long period in order to be able to heal. And then we must do anything we can in order to increase the biological activity that heals the calf. And we have now biological scaffolds and also tendon scaffolds. And at the end, when we decide to treat these tears again, it's a staged procedure. It's a way of thinking, starting with the simplest, repairable tendon, anatomic repair. The laminar tendons, bad quality of tendon, try to improve the biology of the repair. If we can't close the repair, do something simple in order to do this, as here with the biceps. If the biceps inadequate, combine it with fascia lata, semitendinous graft, in order to be able to give again the vertical stability. If we have a patient that is of low motivation, a patient that can't follow the rehabilitation problem, can't follow the period that is needed, it doesn't have the resilience needed, then do something simple. In space balloon, tenotomy, just anatomy of biceps, something that is going to minimize the pain and make the function possible in a quicker state. And of course, when you don't have motors, you need motors. Try to bring more motors into play. Last and not least, a very effective way to restore the function, to give strength, to stabilize the center of rotation by a mechanical way. And it is something that we use all and more now in massive calf tears in these ages. So, conclusion, every patient must be treated according to the anatomic lesion, but we must not stay in the anatomic lesion. It's one part of the thought process. How he compensates is very important. Compensation means that nature finds a way to give again the function and solve the problem. and what are the expected needs, what the patient is expecting. You can do the best reconstruction, the best operation to a low motivation, motivate patient, and you are going to have a very bad result. Treatment of small and medium rotator cuff tears, practically now we know how to do it. It's going to be successful. Large, massive, irreparable tears, these are the problem. And there now have many solutions. So let's try to be cost effective. Cost from the point of economical cost and cost of the point of time the patient is out of function, because this is equally important. And at the end, let's try to study principles to understand best what is happening, because then the methods are there. What is needed is creativity. Thank you for your attention.